ma'am.
Okay. With that, I will proceed to introduce our next keynote speaker, Dr. Kate Drummond. She is the Director of Neurosurgery at the Royal Melbourne Hospital and Head of CNS Tumors at the VCC Parkville Precinct. Published over 150 papers and is doing some groundbreaking work and research in biology and management of brain tumors. This is her special interest, I believe. With many other accolades, she was recently awarded Member of the Order of Australia for services to medicines, particularly in neuro-oncology. With that, I invite Dr. Kate Drummond to give her presentation. She will be talking on controversies in spinal surgery. Dr. Kate Drummond.
Thank you very much. Can you hear me and see my screen?
Yes, ma'am.
Excellent. So thank you so much for inviting me to speak in this wonderful session with many other eminent women, and thank you to the organisers. I'm going to talk about controversies in spine surgery, and I would emphasise that I'm largely speaking about spinal surgery for degenerative disease. I think, the situation, in paediatric abnormalities or infection or tumour is entirely different. So I'm largely talking about controversies in spinal surgery for degenerative disease, for back pain and sciatica. So in Australia, this is actually really an epidemic. So this is slightly old data, but the continuation data is exactly the same. We have an epidemic of spinal fusion surgery. And interestingly, well, it's almost a pandemic because it's around the world. Interestingly, this is a pandemic of those with private health insurance. In New South Wales, the largest state of Australia, you can see that there's not much change in the amount of spinal fusion for publicly insured patients or Medicare patients. Whereas for insured patients, from about the year 2000 onwards, there has been an exponential growth in spinal fusion, particularly for degenerative disease. And of course, this is a market that never ends because everybody has back pain at some stage in their life. Everybody has leg pain. So this is a market that never ends. The trend is exactly the same in the United States. This is posterior lumbar fusion in the United States. And of course, the most accurate data comes from the companies that sell the screws and the plates and the cages. And they show a year-on-year growth. This is $1.8 billion and only in 2016 and only continuing through to 2028, the projected market share. So we can tell that, this is a very lucrative position for the surgeon, probably for the private hospital and for the industry. So this does bring a lot of controversies with it. And these are the controversies that I'm going to talk about. The problems with spine surgery for degenerative disease is we don't actually understand the disease. We don't know what the pain generator is in many situations. We don't understand or we disregard the placebo effect, and therefore we overestimate the effectiveness of our surgery. We've allowed the industry to drive the field, and the industry are not subject to an adequate regulatory environment. And we ignore the evidence that we have because we know better. So we don't understand the disease. You'll see here, of course, two completely identical MRI scans. And on one of them, I've said one is a 64-year-old woman with debilitating back pain on opioids and a disability insurance for more than 10 years, and you would believe me. And on the other one, I've said this is a 64-year-old woman with no back pain and occasional sciatica managed with simple analgesia, and you would believe me as well. So if the two scans can result in two completely different outcomes, we don't understand the disease. We don't take into account physical, social, or personality factors. We don't understand the inability to cope with the pain because of those factors. We don't understand the multidisciplinary process and who else may be able to help this patient. we find it really difficult to say no. A patient comes to us begging that we cure their pain. And even if we don't really have something that might cure the pain, we find it hard to say no. And we have no biomarkers of prognosis or severity. So it's unlike in brain tumours where we've got biomarkers that says this patient will do better than that patient, this patient will respond to this chemotherapy, whereas this one don't. We haven't really researched biomarkers of severity or response to treatment. So we need to start doing things that will help us to understand the disease. A particular problem is we don't understand or we disregard the placebo effect. And placebo effect is very important for pain because pain is entirely subjective to the patient. It's not really measurable. There was some really groundbreaking work done many years ago related to knee arthroscopy. So in the 1980s, knee arthroscopy for osteoarthritis was heralded as the great cure for knee pain. And all of the studies showed that if you randomise patients to knee arthroscopy or physiotherapy, then the knee arthroscopy patients did much better in relation to their pain scores. But then we did a bunch of trials were done, published in the New England Journal of Medicine in 2002 was the first one, which compared knee arthroscopy versus sham surgery, 2 small cuts made on the knee, but no actual arthroscopy. And they showed that the pain scores and the disability scores were exactly the same for the sham operation and the placebo operation, showing that surgery really is the ultimate placebo. The placebo effect is very important because for any therapeutic effect, we have to assume that it's both the specific therapeutic effect and the placebo effect that leads to the perceived therapeutic effect. Even for something for which there is no therapeutic effect, something which is completely inert, there may be a perceived therapeutic effect because of the placebo effect. And the placebo effect in spinal surgery is about 30%. So if we think about 30% of our patients' back pain gets better with fusion surgery, of course, it could be all placebo. And particularly if the disease has natural fluctuations in severity, it tends to be a little better, a little worse, depending on activity, depending on, life circumstances, then the therapeutic effect will be the placebo effect plus or minus natural fluctuations, which if they're for the better, can make the perceived therapeutic effect look very high. And what makes a great placebo? Well, patients need to believe it will work. The effects need to be intuitive. And that's very true of surgery. If I've got back pain, putting screws in my back, surely that will help, doctor. That makes sense to the patient. The doctor needs to believe it will work or be able to convince the patient that she believes it will work. And more is better. So the bigger the size of the operation, the cost or the perceived cost, the complexity, the invasiveness, patient involvement, or an impressive environment like an operating theatre makes a better placebo. So a sugar tablet that doesn't have a fancy name on it will not have as good a placebo effect as a big operation that costs a lot of money by a very fancy surgeon with a fancy office that's going to take a lot of rehabilitation afterwards. That will have the surgery will have a much better placebo effect. And it's really great if the placebo has a good name. So Panadol is the Australian name for paracetamol, and exactly the same drug is called Panamax. But the max was great. Patients often say, oh no, I take Panamax because max must mean maximum. So it must mean it's a better drug. So the placebo effect is very important. And if you think the placebo effect's not important, because we have a lot of sort of phase 2 trials in surgery, you'll remember Avastin, which was supposed to be the great hope for recurrent glioblastoma. The Avastin was supposed to be, the bevacizumab was supposed to be the great hope for it. And it was fast-tracked through the FDA on the basis of a number of phase 2 trials that showed fantastic effects. So when the 2 phase 3 trials came out, one American and one European, it showed that the entire effect of the Avastin was the placebo effect, because when randomized, there was absolutely no effect whatsoever. So it happens for drugs, and it certainly can happen for surgery. There's good studies that show that if you say that a pill costs 10 cents and if a pill costs $2.50, the $2.50 pill will actually have more placebo effect. So imagine how much that is for surgery. We've allowed industry to drive the field. And industry is a real problem. This shows a number of publications that show drug trials, non-surgical, non-drug trials, and surgical trials. And anywhere where industry is involved in the publication, the result will always favour industry. It will be positive. But this is particularly true for surgical trials. So we know that a lot of the literature that we base our thinking on is based on problematic literature. And of course, the companies come up with these wonderful slogans. Innovation is in our DNA. We change a patient's life every minute. We show up every day united and committed to change a patient's life every day. So they certainly hook us in and they hook the patients in that they're doing all of these wonderful things. But this, of course, is business, and I don't blame them. Their job is to sell things. This study in the Spine Journal shows, though, that we're not told the truth. And this looked at the disclosures for funding between what was disclosed at the North American Spine Society versus what was disclosed on the industry website for surgeons and how much money they were receiving. And they showed a 30 to 40% discrepancy in what was disclosed at the North American Spine Society versus what was disclosed by regulation, buried right down the bottom on the industry website. So we're not always told the truth about what's important. So, and we know that the industry doesn't have the same regulatory process. If you want to develop a drug, you do R&D, you do preclinical and animal testing. You go through phase 1 to 4 clinical trials. You're reviewed by government regulatory agency, TGA, FDA, and then finally you go into post-marketing safety monitoring. If you're a device developer, you do just R&D, and then all you have to do is show that it's safe and it's not worse than anything else. So the purple screw and the green screw being better because it's coated with something very special, doesn't actually have to show that the green screw is better for that company. All it does is have to show that it's safe. And then it goes into post-marketing. So there's major gaps in implementing and evaluating devices. And we ignore the evidence that we have. You heard me talk about the knee arthroscopy. And despite the evidence that knee arthroscopy didn't work, there was still an increase after the publication in 2002 of knee arthroscopy, partly for osteoarthritis, but also in total knee arthroscopes, which people then said was for meniscal tear instead. So the rate of meniscal tear, which is supposed to still the knee arthroscopy is supposed to work, increased markedly. So we just swapped what we call the procedure with for. And we've got lots of evidence, for instance, that laminectomy doesn't really need fusion if you've got a small slip. And yet many of my colleagues will continue to fuse patients with a small slip because they say that it will treat their back pain. But we have quite good evidence that that is not the case, but we ignore it. We say, oh, it wasn't a very good trial, or oh, I do my fusion a different way, or oh, they didn't choose the patients properly. But rather than creating better evidence, we just ignore the evidence. The same for vertebroplasty, which is still performed the world after for osteoporotic fractures, but has a massive placebo effect. So what are the solutions? We need longitudinal population-based studies of MRI findings in aging people and understanding their pain. We need to know what the MRI scan findings are that are associated with different types of pain, whether there's any association, and what the other factors are that are associated with pain that makes us know that we can see the same scan in 2 different people but have 2 different pain complexes. We need to do randomized or sham or placebo studies, particularly on all of the injections and denervations and nerve root injections and everything. It's very easy to do sham studies for those to determine whether they work. And we really need to do randomized and sham studies of spinal procedures. But if you think that that's a bridge too far, although there is one undergoing a sham study happening in Australia at the moment, then we at least need to have worldwide registries that show the effectiveness, the real lifelong effectiveness of these procedures. We need to lobby government and philanthropy to fund spinal procedure research rather than companies. We need to lobby government to hold device manufacturers to the same standard of evidence as pharmaceutical manufacturers. Imagine if the screw makers had to actually prove that the screw that they made was better than anyone else's screw before it got approved. Imagine that. Most of the stuff that's on the market would not actually be on the market if they had to prove their use in a randomized controlled phase 3 trial. And we need stricter rules on publications. I'm a journal editor, and I now refuse to publish small studies, never powered to show a difference, that tell me that this cage covered with this and this cage covered with that is better or the same or different, because they're not even powered to show a difference. And they're not followed up long enough to prove that that difference is real. And we need to apply the evidence that we have, and we need to produce more and better evidence. Thanks very much.
Thank you, Dr. Kate. I think this indeed is one of the most important controversies in spinal surgery, the use of implants. And yeah, like you said, much of it is industry driven, and we are, we ourselves are perplexed. What works in one patient doesn't work in other, or like the same scans show different presentation in different patients. So, yes, I think as far as spinal surgery is concerned, especially in degenerative spine, we have a lot more to learn, study, and come to a consensus as to how the treatment of these patients should be done. I think whatever you presented was absolutely eye-opening to most of us. And yes, like you said, it's probably more simple to produce an implant and market it rather than being in the drug industry, which is rather more difficult and more tedious. Thank you very much for this absolutely wonderful presentation. And is there any questions or anything that I can take? I can take a couple of questions.
Can I have a question, Shraddha?
Yes, ma'am.
Dr. Kate, congratulate you because you have touched on a very sensitive thing, and this is so very much relevant. Actually, this industry people, they actually build a perception among the younger colleagues, and they feel like now the endoscopic discectomy, we get so many cases where, they fail, they just take out a little bit and they come back, and then but then, the younger people, the newer residents who are coming out, they always feel that endoscopy is the thing, microscopy is gone, like you cannot do it. So it's so much industry driven, and I don't know where we should look at it. Like many of our local made implants are quite good, but then the perception is that if you use the local implants, it's going to fail, but that's not the case, we know. But,
I'm such a big fan of the Indian implants. Every time I have a shunt manufacturer come to me and tell me that I need this special shunt with an anti-siphon and a this and a that, and I say, no, I just like the Chabra shunt. If only I could get it here in Australia. Local implants, not passing this massive cost on advertising cost and flying people all over the world cost onto the patient, because that's who it gets passed on to, the patient and the government, I think is really important.
Thank you very much for touching this.
Thank you so much, Dr. Kate.